so very much for the kind introduction. Hi, Viveka Kumar. Hi, Dr. Mohapadra. It's a privilege. And Viveka had made my job simple, I think, because he had to cover most of it. What I'm going to be talking, and that is specifically, again, probably the revision of what he had told. And that is the highlighting the cardiac resynchronization therapy in chronic congestive heart failure. So what he was discussing, I'm repeating here, it is the conventional cardiac resynchronization therapy by pacing involves right ventricular apical pacing simultaneously or near simultaneously with the left ventricular pacing by an epicardial lead placed endocardially through the coronary sinus into the tributary. So the near simultaneous biventricular pacing is synchronized with atrial sensing or an atrial pacing, and that is connected with the conventional pacemaker. Like for example, here there are 3 leads. And at the end of the procedure, if you are achieving really very well separately placed and appropriately placed leads, the ventricular and atrial side, you feel that you have done a good job with respect to the pacing therapy for the resynchronization. If you are looking at who are the classical candidates or what is the indication for cardiac resynchronization therapy for heart failure, is that the patient needs to be symptomatic due to severely impaired left ventricular dysfunction. With or without right ventricular dysfunction, he has to be symptomatic despite optimal medical treatment. On top of that, if this patient remains in the sinus rhythm at the time of the implant, and he has a typical left bundle branch block, and the QRS is wider than 150 milliseconds, it has been seen that most likely the person would get benefited with the CRT.
In that segment,
if you are looking from the electrophysiological perspectives or from the electrical and mechanical coupling perspective, this slide is going to show the mechanism of benefit of cardiac resynchronized therapy by pacing. Electrocardiologically, if you are looking at a patient who is in that class 1 indication where he has a wide QRS and the sinus rhythm at any given rate of sinus rhythm, and a wide QRS and a longer PR interval, you tend to have an increased pre-aortic ejection time. And the wider QRS resulting in the mechanical dyssynchrony would result in the reduced cardiac output as compared to when you try to get this wide QRS made narrower. With the same kind of PR interval, you tend to decrease the pre-aortic ejection time and you improve the synchrony, and hence you end up in getting the increased cardiac output as compared to the basal level. On top of that, if you also reduce the PR interval physiologically to a level acceptable so as to increase the diastolic time. So you increase the synchrony, increase the mechanical effectiveness, and you increase the diastolic period. So essentially, you increase the left ventricle, or sometimes you could also demonstrate you increase the biventricular systolic output. You demonstrate most often decrease in the MR, both diastolic and systolic components of the MR. And then there are occasions where you have chosen a right candidate and you have done the right way of implantation. You could demonstrate that the patient's quality of life improved, his survival increases. And over a period of time, you could also demonstrate the reverse modeling, provided you have taken an appropriate candidate and done the procedure appropriately. But there are occasions where on the table itself, you're not feeling good because the placement of the leads was not okay, or maybe the QRS, what you thought would narrow, it didn't become as narrow. So it is at that point you will have to take some critical decisions, and not just placing the leads at those places where you thought it was possible, but maybe you will have to take the help of your surgeon, because ultimately what is important is to the patient, for example, in this case, who with great difficulty, has agreed upon for a most expensive therapy in the medical field, and that is the CRTD. He has, and then if you are putting a lead somewhere, it wouldn't probably benefit. So CRT results can be improved upon if you also take your surgeon's colleagues in your practice and make the surgeon to place at the right place in case you are unable to do it. That is how you increase the responder rate. So in addition to this classical case of a symptomatic patient, severe LV dysfunction, sinus rhythm, LBBB, there are certain soft indications. For example, where you can still have a benefit from CRT. So for example, the class 2A or class 2B indications where the benefit is doubtful is those situations where you have a wide QRS. You can describe them in general in the context of a CRT as a non-LBBB kind of a interventricular conduction defect with the QRS with, say, for example, 130 to 150. It is this particular population where cardiac resynchronization therapy is still doubtful, and in the coming few minutes, I'm going to be concentrating on this particular subset. How to increase the response rate? For example, if you have an atypical RBBB or a non-LBB but looks like an atypical RBBB, you can still take a chance depending on certain ECG characteristics. For example, there are absent S waves in lead 1 and AVL. If this atypical RBB is associated with the leftward axis, PR prolongation, maybe you can think about doing the CRT in that. If it is atypical LBBB, again, there are certain QRS features either in the precordial leads or in the limb leads with respect to the notches in the R, and that is also associated with LAD. And in both these subsets, the PR prolongation is what also makes you feel comfortable in recommending the CRT. When you address this kind of a doubtful responder to CRT, there are certain things which have come into our aid, which I would call them as the recent advances in CRT, where your patient has a wide QRS, but not necessarily the so-called typical LBBB. And these recent advances are also applicable to the typical LBBB subset as well. And what are those? And Viveka had given some kind of a hint about achieving the cardiac resynchronization therapy apart from the conventional way of right ventricular and left epicardial pacing. And those are His bundle pacing is one which can take care of any kind of intraventricular conduction defect, not necessarily typical LBBB. Left bundle branch area pacing is another area of interest, which is showing some promising results. And what we usually do in our hospital with respect to the intraventricular conduction defect is to actually identify the right sites of placement of the leads with respect to the electroanatomic mapping. So for example, if you have an ability to place the lead, the lead at the His bundle, and if you have demonstrated that in the His bundle area, you are able to capture the right or the left bundle component, and then if you demonstrate that the block is proximal, maybe a dual chamber pacemaker would serve as a CRT unit here, because this particular lead, which is screwed into the His bundle area beyond the level of the block, may still carry the impulse down the healthy vesicles, and then you may end up in having a narrower QRS, whatever the reason, whatever the kind of a wide QRS it was. So His bundle pacing is showing some promising results in those patients, not only with LBBB, but also with the non-specific intraventricular conduction defect. Another area of interest is to actually pace deep into the septum, where the left bundle is still hugging upon to the ventricular septum on the left side. So if you pace the intraventricular septum deep in by a lead brought into the right ventricular endocardial aspect, you might get simultaneous activation of the right and the left bundle. For example, if you have documented the His potential in this area, go down below that and try to demonstrate the intraventricular septum by an angiograph. And here, if you have potential, or if you pace here and if there are certain features on the ECG by pacing, if you think you are about to be capturing both the fascicles, maybe it is worthwhile to go further and screw in. For example, there are special leads which can bring the lead deep into the septum, and there are certain hardwares which will help both the cathode and the anode to capture the ventricle. So the right-sided bundle and the left-sided bundle can be simultaneously be paced, and if the block is proximal, the impulses will go down the healthy part of the conduction system, and you may get a good QRS. For example, in this particular case, you demonstrated that you placed a lead beyond the His bundle, and then you also looked at the LAO view where you demonstrated that it is perpendicular to the interventricular septum, and certain characteristics on the electrograms you have shown there's a left bundle potential, or by pacing you looked at the 12 lead ECG during pacing, and if you think you have got an narrow QRS, this probably obviates the need for another lead to get the synchronization. Another interesting area, maybe time consuming, and maybe the hardwares may be more, but if your goal is to achieve cardiac resynchronization therapy by pacing, the moot point here is where are those points of pacing? And if you document which is the early site of activation and which is the late site of activation by electroanatomic mapping, and if you have tagged those spots and there are hardwares, you can bring in the leads and then stick there. For example, let's look at this so-called right bundle branch block. The electrical activation or a depolarization pattern of the ventricles in the presence of the right bundle branch block. So for example, so this is the diastolic phase where none of the ventricles, this is the right ventricle, this is the left ventricle, they're not depolarized. When you start the depolarization, you will notice that the first part of the activation is from the left ventricle because the right bundle branch block. And once the left bundle branch block is, left ventricle is activated, then only the right bundle will start. For example, the propagation is now across the septum. This is the breakthrough point into the right ventricle. So you have identified on the left side where was the earliest activation. You also identified the right ventricle is too very late in its activation. You have found out where is the break point. And then if you further map, you would notice that this particular area, the outflow tract area, is the latest of activation. So you found out the earliest activation, you found out the breakaway point, and you also found out which is the latest site of activation. So if you tag them and then if you bring the lead at the earliest activation or in the latest activation, or if you bring a single lead at the breakaway point, where exactly, so then you may actually cause significant reduction in the activation time, or in other words, significant narrowing of the right ventricle. You could also, for example, verify whether you have done a good job on the table. For example, in this particular case, a left bundle area pacing. Are you sure that you have done a good job? So this is how the activation map could be performed, and you would notice that this is the site of activation, and look at the activation time of both the ventricles. They are near simultaneous. And if you look at the time interval here, it is less than 90 milliseconds. Both the ventricles are activated simultaneously. So what I'm trying to say here is the advances are tremendous. It is easy for us to figure it out where exactly is the early site of activation, the breakaway point, or the latest activation. And then there are hardwares you can go in there, and hence you can significantly increase the CRT responder rate. There are certain other techniques which are evolving. And for example, with a dual chamber ICD, you may get the benefit of the CRTD. For example, few cases in our center, what we have done is placing the ICD lead. the pacing the ICD lead at the his bundle and screwing in. Well, there are certain limitations that are associated with us because we don't want this particular lead to sense the atrium, and the R waves probably are going to be less. But in select cases, if this is achieved, and if in the future the hardwares are such that the defibrillator lead could be placed at the his bundle, or a defibrillator lead could be placed deep into the septum for the left bundle area pacing, we may end up in having fewer leads but still get the results equivalent to the CRTD. For example, here it is at the his bundle, and in this case, I think it was there into the left bundle area. So we can do the parahesian ICD using a dual chamber ICD, but you can achieve almost equivalent to CRTD benefits. There are other ways of looking at things. For example, we have some leads which are called DXICD leads. In this particular case, a single lead which has a defibrillation coil distally, and in the proximal, you have a dipole which can sense the atrium. So a single lead, and if this lead is at the his bundle or at the left bundle, and if the parameters of the leads are as satisfactory, you may end up in having a single lead and CRTD therapy. So I think the coming days are quite exciting. We are reducing the number of leads. We are probably making the procedures more simple, and hence we may provide this kind of a benefit to more number of patients. Viveka had shown another way of doing CRTDs. For example, in this particular case, if you have an RV coil placed like in the textbook, where in the apex, well, and then you also have placed the so-called the LV lead in the textbook way, and you use the best of the leads. For example, this is a screw-in LV lead, is a quadrupole, multi-side pacing, all that thing, but still the QRS may not be wide, or maybe there are some issues with the pacing area characteristics. In that case, in addition to this, you can do a multi-lead use. For example, here another lead was placed. So this is you can call this as a his bundle pacing optimized CRTD. And if you bring that lead into the septum, and if you put it into the septum, you can call that LOT CRT, that is left bundle area pacing optimized CRTD. So there are many ways by which we can achieve cardiac resynchronous therapy by pacing. So with this, I would like to end. And of course, like Vivek, I would also wait here for the questions which may come up. Thank you, Vanita.